Ok. Olá, pessoal, boa tarde. Aqui é o professor Jander, diretor da unidade da Uninasal Sobral, dando seguimento aí ao nosso evento, o nosso primeiro fórum universitário sobre envelhecimento saudável. Nós temos a honra de receber agora conosco o professor Mark Haykowisky, PhD, professor, reitor de pesquisa, né? Lá no Canadá eles têm essa função, esse cargo. E ele está conosco hoje para falar um pouco da sua experiência o trabalho da fisiopatologia do exercício em adultos idosos, né, em older adults, né, professor Paulo, em idosos, e essa relação dessa fisiopatologia com as atividades cardíacas e os exercícios, se é bem assim que eu entendi. Então, temos aqui a presença do professor Paulo de Tarso, professor da Uninasal, vai nos ajudar nessa condução. Eu, inicialmente, vou passar a palavra para o professor Paulo, e logo após o professor Mark. Eu vou falar um pouco em inglês agora, só para que o professor Mark e os nossos ouvintes em inglês possam nos compreender. Hi, good afternoon, Professor Mark. Good afternoon, Professor Paulo. It's a great pleasure to us, a great pleasure to Uninasal University of Sobral receive a great nursing like Professor Mark. It's the first time we realize an event like this forum. Então, so it's a great pleasure. Então, to me, as director, to Professor Paulo as professor, and all the students of nursing of Uninasal, this is a historic moment. So now I will asking for Professor Paulo if you have any words to presentation, Professor Mark. Professor Paulo, good afternoon.
Good afternoon, boa tarde para todos. We are here with Professor Haykowisky. I guess that I'm writing your name. I'm sorry if I said some mistakes, but Professor Mark Haykowisky is a professor at the University of Alberta in Canada. He's a professor. Professor Mark's research about biological mechanisms responsible for the decline in health-related fitness in cardio-oncology, with focus on the role of exercise training to prevent cardiovascular conductions and cardiotoxicity associated with anti-cancer therapy. Am I right?
That's correct. Thank you.
Okay. Professor Haykowisky, please be welcome to our event. And now I give you your floor. Please make yourself at home.
Thank you. Thank you very much for the very nice introduction, and thank you very much for the invitation to speak. Today, I will talk about exercise intolerance in the older adult with heart failure and preserved ejection fraction. I do not have any disclosures to declare. So in the next 35 minutes, I will briefly talk about the global burden of heart failure. And I'm sure for the students who have studied in nursing or studying in nursing, you have talked a little bit maybe about heart failure. So I'll talk a little bit about one type of heart failure and preserved ejection fraction. I'll talk about the importance of exercise intolerance in HFpEF, heart failure and preserved ejection fraction. I'll talk about fitness. So this is a measure, peak aerobic power. This is a measure of fitness and how this changes in health and disease. I'll talk about fitness required to perform activities of daily living. And then I'll talk about what causes the impairment in exercise tolerance and how do we improve that with training, exercise training. So the prevalence of known heart failure is estimated at around 1 to 2% of the general adult population in developed countries. And it's estimated that 64.3 million people are living with heart failure worldwide. Over 50% of heart failure patients in the general population have preserved left ventricular ejection fraction. And for those who are not familiar, that's just the amount of blood you pump out of the heart relative to the amount of blood that comes into the heart. So that's called left ventricular ejection fraction. And normal is somewhere around 50 to 60%. And among older women, over 80% of new cases of heart failure are heart failure and preserved ejection fraction. So this is a type of heart failure where the individuals have symptoms of heart failure, but they have a normal resting ejection fraction, but they still have heart failure. And heart failure is associated with a high morbidity and mortality. And after hospitalization, the 5-year survival rate of HFpEF is 35%. So many of the students and nurses obviously will see heart failure patients or heart failure preserved ejection fraction in the clinical setting or the hospital setting. And numerous studies have examined the mechanisms of exercise intolerance in heart failure and reduced ejection fraction, so where you have a big dilated heart that doesn't pump very well, but few data are available regarding the mechanisms for reduced peak VO2 and HFpEF. And our understanding of the HFpEF pathophysiology is incomplete, and optimal treatment remains uncertain. So basically, this slide is highlighting that this is a major healthcare problem with a high morbidity and mortality rate. So the hallmark feature of heart failure and heart failure with preserved ejection fraction is exercise intolerance. So our heart failure patients will often complain of being fatigued or short of breath, even with minimal level of exercise. So this is important because we want to determine why they are fatigued and short of breath, and how can we improve that so they can function independently in their environment. And that's the key with aging, is we want to maintain optimal health and fitness so individuals can function independently on their own, and they don't require others for assistance with activities of daily living. So as I said, exertional dyspnea, so just shortness of breath, and fatigued, feeling tired, these are the major symptoms of heart failure. And reduced exercise intolerance or reduced exercise capacity is a major contributor to impaired physical function, reduced quality of life, and it is a predictor of mortality in heart failure patients. So the lower your fitness with heart failure and HFpEF, the higher the mortality and impaired functioning. And again, this measure you'll hear me talk a lot about today, peak VO2, that is just the measure of fitness. So if you were on a bike or on a treadmill and we could measure how much oxygen you use, we could determine your peak VO2. It's standardized, it's objective, and very reproducible. So this is just a slide that I've put together a number of years ago, and this is just your VO2 peak on the y-axis, or your fitness level. And here is a group of individuals of athletic individuals from papers all the way down to heart failure patients. And what you could see is very, very, very fit marathon runners. So people who run a marathon have very high fitness at the elite level. Not every marathon has a fitness this high, but from this study, the average fitness was 90. And even this is males, and even elite female athletes have scores a little bit lower, but still very, very high. And this is an individual who had competed in the Boston Marathon 32 times, and he won it 7 times, and is a very high fitness of 60 mils of oxygen per kilogram. And then young athlete is somewhere 57. And then, because it's important, this theme of this conference is aging, you could see as we age, your fitness declines by about 10% per decade or 1% per year after 25. So as we age, our fitness becomes lower. And that, unfortunately, is an aging phenomenon. Now, individuals who exercise later in life, they can improve their fitness, but they still will have lower fitness than someone who's exercised their whole life. And here's an older individual who's sedentary and does not do very much exercise, and their fitness is lower at 26 compared to someone who's an elite marathon runner, 90. So almost 3 or 4 times lower. And then these are the heart failure patients. that are typically in the literature, they have fitness levels of 13 and 14, and that's well below the fitness level for independent living. So as we see, fitness is very important throughout the lifespan to maintain your overall cardiorespiratory health. As we age, we lose our fitness, and in health, we will still lose fitness as we age, but in heart failure, unfortunately, they've got very low fitness levels to the extent that they don't function as so well in their environment. And I will show you this in the next slide. So this is just a slide from a colleague of mine in Boston in the United States, Greg Lewis, in a paper he published, a review in JACC Heart Failure. And here is again your VO2 or your fitness level. And then here are activities of daily living. So rest, dressing, making a bed, sweeping or vacuuming, walking very slow, the fitness for your independent living, and then carrying groceries or jogging 5 miles per hour. And again, here is just your fitness level, and you don't have to worry about this or this description, but this is the fitness level for heart failure patients from a number of studies that they just took the average value. And here is the fitness level required relative to your peak fitness in HFpEF. So what I'm saying is just at rest requires 23% of your maximal fitness level in a HFpEF patient. So just doing nothing and sitting at rest, listening to me talk for our heart failure patients is about almost 25% of their peak. Putting your clothes on or making a bed or getting dressed in the morning almost requires 60% of the peak effort of our HFpEF patients. So even when our patients are making their bed or dressing in the morning, it requires a very high effort compared to their peak. And if you're doing sweeping or vacuuming in the house, that requires 70% of your peak effort if you're a HFpEF patient. And walking very slowly is almost 80%. And just functional independence, just being able to be functionally independent in your environment, your house, your home, requires 21% more than their peak effort. So this is really an important slide because when our patients tell us that they're short of breath and fatigued, even just getting dressed in the morning, it makes sense because it almost requires 60% of their maximal effort. So what's really important for rehabilitation and in nursing is that where possible, we have to make sure that we get people up and moving and active as much as possible. Because if we sit and do nothing and stay in bed all day, we become very deconditioned. And in fact, you can age by 30 years to 40 years after 20 days of strict bed rest. So it's really important within the constraints of any disease, as long as people are able to get up, we need to move. Because if we don't, we lose our fitness, which is very, very worrisome. So the take-home message is that even small activities of daily living, like walking or dressing or making a bed, require almost 60 to 80% of our heart failure patients' maximum effort. So an important goal is to increase their fitness so they can function more independently and better when they're living each day. So this is kind of a very technical slide. Don't worry about the slide. But again, this is from Greg Lewis's group in the Massachusetts General Hospital, Mass General in Boston. They did a nice, beautiful review in the prestigious journal Circulation. And anything, ultimately, to measure someone's fitness, we utilize oxygen in the mitochondria, in the muscles. But we have to transport that oxygen from the pulmonary system. We have to carry it in the hemoglobin, and you have to pump out blood from your heart, and you have to deliver that oxygen to the working muscles. So anything from the lungs, the heart, the blood vessels, and muscles can limit your exercise tolerance. So anything along this oxygen cascade, bringing oxygen from the air that you breathe in, all the way down to your muscles in the mitochondria to utilize oxygen and ATP for energy, can limit your performance. And this is just a slide that we published a few years ago when Wes Tucker was working with me when I was a professor in Texas. And we find again that you expect that our fitness level of the HFpEF, that's in red, is lower than age-matched controls. Why is that? Because the heart doesn't pump so well. So the ability of the heart to pump out blood is lower. But also, we have abnormalities in the blood vessels and how the muscles use oxygen. So as a consequence, you may be familiar with something called the Fick principle, which is your cardiac output times your arterial venous oxygen difference. So how much blood you pump to the muscles from the heart and the blood vessels, and how the muscles utilize oxygen. And both of those are lower. So your pumping ability, your cardiac output is lower because the heart rate is lower. So how much your heart is beating with each beat is lower beats per minute and lower pumping with each beat. Also, the heart is more stiff. It does not relax as well, and it doesn't pump out as blood as well. And also the blood vessels are more stiff, and the muscles also the vasculature is impaired. It doesn't deliver oxygen so well. And in the muscles, we have lower oxidative fibers, lower capillaries around each muscle, and the muscle mitochondria is not so good to utilize oxygen. So as a result, the overall thickness is lower because the heart doesn't pump so well through the blood vessels that are a little stiffer and muscles that don't use oxygen as well. So this is an important slide because it's very difficult to change heart function when it's damaged, but we can improve the blood vessel and muscle function. And we use the term plasticity. So muscle has a large plasticity and we can improve its function. So this is important because most of my talk now will talk about the blood vessels and the muscles, and especially muscle function, because we can improve that with exercise training. Very difficult to improve your heart function when a heart is damaged. Okay, does that sound good so far? Because all I see is my screen. So I apologize if I'm speaking too quickly.
No, it's perfect.
Okay, now let's talk a little bit about the blood vessels, because very important, we have to increase blood flow to the muscles, and we call that oxygen transport. And this was a very nice study by the group in Utah, Russ Richardson's group and Walter Ray. And what they did is they have a very unique exercise where you only exercise one muscle at a time. This is called one leg or single leg knee extension. So if you're sitting down and you just kick your leg out, that's knee extension, okay? And why this is an important exercise, because it's very small muscle mass. And when you have very small muscle mass, the heart is never limiting, even in heart failure patients. So it allows us to look at the blood flow to the muscles in isolation. And what you can see here is in this study, they compared control subjects who were the same age as the heart failure, or tried to match closely the heart failure and preserved ejection fraction. Here is leg blood flow. Here is your blood pressure. And here is the resistance of blood flow through the muscles. And then you can see we have rest, no workload, and this is now 5 watts. That's very low workload, 10 and 15. And this is very important because even though the heart is not limiting when you do small muscle exercise, our heart failure patients, you can see, are in this gray circle. They have lower blood flow at the 10 and 15 watts. So this is really important because even when the heart is not limiting and you isolate the muscles, blood flow is lower to the muscles. And that's very important because you need to get more blood and oxygen and nutrients to the muscles when they exercise. So why is blood flow lower? Well, the blood pressure seems to be very similar, mean arterial blood pressure. You can measure that with a blood pressure cuff during exercise. But the resistance to blood flow or conductance, which is the inverse of resistance, we see is lower, so they have higher resistance to blood flow. So the blood vessels are not working as effectively in our heart failure patients, and they're more rigid and flow is harder to get through. Now that's when one leg exercise, but also when we do larger exercise with the legs, so now you're doing cycling, we also find not only is the blood flow lower, but the transport of oxygen. So remember, we have hemoglobin that carries oxygen in the red blood cell, but we also have to have this transport of oxygen from the red blood cell into the muscle mitochondria. So not only is blood flow lower to the muscles, but the transport of oxygen from the little red blood cell in the capillaries to the muscles is lower. So this, they measure something called, and this is kind of complicated, so don't worry about it. There's no test question, hopefully, on this. But the transport of oxygen from the red blood cell to the mitochondria is lower in our HFpEF patients. So I show you this slide because it's important, because we can maybe improve blood flow and muscle function by doing exercise on a bike or knee kicking exercise. So this is very, very important slide because the muscles, we can improve their function and blood flow with exercise training. So although heart failure patients, their heart doesn't pump so well, our research and others show that the muscles' ability to deliver and use oxygen is also lower. And why that's important is because we can improve that with exercise training. So Brazilian soccer players, they have very high blood flow, I would imagine, and they have very good muscles to use oxygen when they're playing in the World Cup. So this is a slide that's very interesting that we published a number of years ago, because the muscles use oxygen when you exercise. But if you have lower muscle mass, maybe the reason why you have low fitness is because your muscles are just smaller and you have less muscles to use oxygen. So here is just a measure again of your overall fitness when we measure this on a bike, and now HFpEF is in blue, I changed color, and the healthy control is red. So the fitness is lower in liters per minute or mils per minute, and when you measure fitness and you divide by your body weight, it's still lower. Now, when you actually measure how much muscles they have in the body in the HFpEF, their fitness is lower when we measure this relative to their muscle mass. So when you account for lower muscle mass, the fitness is still lower. And when we look at how much muscle mass is in the legs that are cycling, and you measure the fitness level and you divide by the muscle mass, it is also lower. So that tells us that maybe not so much that the muscle mass or the amount of muscle you have is the problem, it's the quality of your muscle. And this slide on the right here shows that this is just a line for healthy controls who are matched to the HFpEF patients, and this is the line for the HFpEF patients. And what you found is that when we look at your fitness level relative to how much lean muscle you have, so how much muscle in your legs, and what you find is that if you're older, the more muscle mass you have, the higher your fitness level. But in our heart failure patients with preserved ejection fraction, it doesn't matter how much muscle mass, their oxygen is still lower for any amount of muscle. So it suggests that maybe it's not the amount of muscle, but the quality of muscle. So what do I mean by quality of the muscle? Well, my colleagues performed a study that I was able to be part of their group in North Carolina. And this is just an MRI, magnetic resonance imaging of the mid-thigh in a healthy subject and a HFpEF patient. And here blue is just the muscle subcutaneous fat. So it's just the fat around your muscle. And in red is the actual muscle. And in green is the amount of intermuscular fat. So this is the amount of fat within the muscles. And this is a healthy control, and this is a heart failure patient, HFpEF. You can see they have less muscle and much more fat. The green is fat. And what's important is this: the more green relative to the red fat is very bad. You want to have more muscle and less fat. And what we find is that people that have more fat relative to their muscle, we call that intermuscular fat to skeletal muscle ratio, is inverse or negative relationship. So the more fat you have relative to muscle, the lower your fitness level. So that's very important, because this was one of the first studies to show in HFpEF that the more muscle fat and the lower muscle, the lower your fitness. And again, this is important because we can improve your muscle with exercise training, with maybe strengthening, lifting weights, or even riding a bike, and we want to lower your fat. So this was one of the first studies to show that not just the problem of less muscle, but the problem of the quality of the muscle. More fat relative to muscle is bad. And you see this sometimes with aging. You lose muscle mass. You actually, sarcopenia, you may hear the term, loss of muscle mass, or a term called myosteatosis, is that muscle have greater fat infiltration, and that is leading to lower fitness. So far I briefly said that the heart is kind of a problem, the muscles are a bit of a problem, and so is the blood vessels. Well, what about exercise training? Well, we've performed a number of studies over the last 20 years on exercise training in heart failure, and so have others. Now, what's really interesting is that even in our heart failure patients, you can still improve your fitness with exercise training, even if you're very unfit, excuse me, or very deconditioned. So with exercise training in individuals with heart failure, with a big dilated heart, or heart failure patients who have a very thick walls of their heart and doesn't pump very well, we can improve your fitness. Your overall peak VO2 or cardiorespiratory fitness or exercise tolerance can improve with exercise training in both HFrEF and HFpEF, both of our heart failure patient phenotypes. Interestingly, a few studies have shown in HFrEF that we can improve your fitness with improvement in cardiac output or no change. But in HFpEF, the few studies performed to date, we don't improve your heart performance. Something called stroke volume is the amount of blood you pump with each beat. So it's the amount of blood your heart pumps in systole when it's contracting. And a few studies have shown we can improve that with exercise training in HFrEF, but we don't improve cardiac stroke volume in HFpEF. Heart rate after training, maybe for 8 weeks, 10 weeks, 12 weeks, maybe 5-6 months, we see no change in either group, or maybe a small little increase. And again, this is very technical terms we don't worry about too much for this talk, but the amount of blood in your heart when it's relaxing or after you've ejected during peak exercise doesn't change. So as a summary for this top part of the slide, what's important is that it appears that all the improvements with your fitness with HFpEF are due to muscle improvements, not to improving heart function. So that's really important because we can improve muscle function with exercise. Now, the blood vessel function can improve with HFrEF or doesn't change at peak exercise after exercise training. And in HFpEF, older heart failure patients, often they're older, female, have high body mass and hypertension. It doesn't improve with exercise training, but the ability of the muscles to utilize oxygen is improved. So in this group of heart failure patients, it seems that the improvement in fitness with exercise training is because your muscles are delivering more oxygen and using more oxygen more efficiently or better. And that's really important because we can change that with exercise training. So again, if for nurses working in primary or secondary prevention, it's really important that we get people to be active within their abilities and within their underlying disease, so that we don't have muscles that become smaller, weaker, and don't utilize oxygen so well. And even in the hospital, for people who maybe are deconditioned, we often will sit them up and maybe do some physical therapy, provided that it's okay to do that within their medical and nursing care. Why? Because just sitting in bed rest, we lose muscle mass, our bones become smaller, and we don't utilize oxygen as well. And again, this is really important because we can improve your fitness without changing your heart function. So how do we do this? Well, this is just from the European Society of Cardiology guidelines on exercise, sport cardiology, and exercise with patients with heart disease. And these are some guidelines. Again, most of you are not going to be working with exercise physiology and rehab, but some of you may in the future work in cardiac rehabilitation. So it's really important that we get our patients who are clinically stable, so they're not short of breath, they don't have acute heart failure, they're on stable medications, that they perform both aerobic or endurance exercise, so riding a bike, going for a walk, climbing some stairs, playing soccer, as opposed to just watching the Brazilian team on TV. That's sedentary lifestyle. We're talking about aerobic or endurance exercise and resistance or strength training. So lifting weights with your arms or over your shoulders or with your legs. For exercise for aerobically for clinically stable heart failure patients, they should exercise 3 to 5 times per week. Some patients may have to do 3 times per day for 1 to 5 minutes because they may be deconditioned. But ultimately, you should exercise on most days of the week, 3 to 5 days per week. And strength exercise should be 2 to 3 days per week. And if you're older, it's important to do balance training, because for older individuals, a leading cause of hospitalization and morbidity are falls. You get up from the toilet and you might fall if you have balance problems, and then you may fracture your hip, and now you're in complete bed rest again. And don't worry so much about intensity, but this is moderate to higher intensity. And on a scale of 6 to 20, somewhere around less than 15. Our heart failure patients should exercise for 20 to 60 minutes, but it may not all be at once. It may only be for 2 minutes. Take a break. 2 minutes, take a break, and then do that 10 times. For strengthening, they obviously should do some lifting of the weights for 10 repetitions or 15 repetitions of upper and lower body extremity. And again, they should progressively increase their program over 3 to 6 months. And again, I'm not expecting you to be exercise physiology rehab, but you should be aware that exercise is beneficial for our heart patients. Even our heart transplant patients I've worked with, we do exercise with aerobic and strength training. No strength training until 3 months after their surgery. But I've worked with heart transplant recipients who've done the Ironman, and they can run a race as quickly as you or I, some of our elite heart transplant recipients. So I'll finish off my talk today, and I can answer any questions, but it's very important in a conference on aging that we maintain overall health and fitness. And the single best way to do that throughout the lifespan, when you're young, middle-aged, older age, or even if you're 100 years of age, it's important that we are physically active and not sitting on our chair, sitting on the couch. And probably many of you are sitting down right now. So everyone should just get up and stretch and lift their arms, because sitting for 8 hours a day for your lifetime is very bad on your heart, your blood vessels, and your muscles. And
Professor?
even our deconditioned heart failure patients, we do exercise. So our heart failure patients have very low exercise tolerance. It is due to their heart, their blood vessels, and their muscle function. And they also have poor quality of muscle, a lot of fat and lower muscle mass. And exercise training, even in older deconditioned heart failure patients who are stable, we can improve their fitness, they function better, and ultimately the goal is to improve quality and quantity of life. We want to add life to your years and have good quality. And exercise training can do this in our heart failure patients, and this is related to the muscles improvement in function. So I will finish my talk there, and it's just been a pleasure to be able to participate in the first symposium on aging and health. And I can answer some questions now if you have some questions. Thank you.
Hi, Professor. Could you put the last slide? Yes, one more, please. One more back. So this is a guideline for patients with the heart failure.
Yes.
This is routine. It's a great routine. Even to normal person, I can see.
So it's a very interesting question, a very good question, because the World Health Guidelines for Physical Activity and exercise are a little bit different. Exercise is a planned behavior, but the latest guidelines recommend that everybody, younger, older, do 150 to 300 minutes of physical activity per week.
All the people.
Yes, or 75 minutes or a bit higher intensity, or a combination. And especially elderly need to do some strengthening and balance. But you are right. Very good question. Even healthy people, young university students in nursing, in medicine, in rehab medicine, physical therapy, in arts, in history, we all commonly should do physical activity every day of the week to maintain optimal health. Because those that do not have time for exercise must have time for disease in the future. So it's a very good question. Yes, very similar to what you or I should do as well. It's just our heart failure patients, we start at a lower level and we gradually build their fitness.
So I was talking that this routine is not a hard routine for anyone. It's an easy routine. But the most people can't do it or don't do it any exercise in your life.
So I do physiology, but I really should work more closely with behavior scientists. Why do I maybe eat a Big Mac and sit on the couch? It's very important because you're correct. We have engineered physical activity out of our lifestyle. I can call skip the dishes and I can have my food brought to me while I'm sitting on the couch. But people say, oh, it's too hard. No, you don't have to do hard. You can play soccer. You can do gardening. You can walk up a flight of stairs 30 times a day. You know, everything adds up as far as physical activity. But we've engineered activity out of our lifestyle. So it's easy not to do anything. But it's really important that we be active because it improves your heart performance, your blood vessels, your muscles. So you're right. We many people, maybe not so much in Brazil, but even in Canada and North America, we're very sedentary.
In Brazil, it's not difference.
I would think you're probably right because the whole world is, and now unfortunately with the pandemic, we've become more sedentary because we had lockdowns, right? So people are now in their house more. So it's even, you know, that we also have a pandemic of physical inactivity, sedentary lifestyle, which has gotten worse during COVID. And I understand, of course, we have to adhere to health guidelines. But even in your house, you can still lift weights and walk stairs or go on a treadmill or a bike.
I think that's important to say, Professor, the difference between exercise and activity. So every human being have activity, but the exercise is a different form of life.
Yes, and very interesting studies coming out of a number of years ago have shown not only are we talking about physical inactivity, but I could exercise and meet all the guidelines, okay? But if I sit for 8 hours a day, 6 to 8 hours a day, and only exercise for 1 hour, my health benefits go down. So not only do I have to exercise, be active for 150 to 300 minutes per week, but every hour I have to get up and walk, even for 5 minutes, because sitting is bad. So when you're in your Congress, if it's not over yet, after every speaker, you should have everyone get up, move for 5 minutes. It sounds silly, but we have to move every hour, because if you sit for 6 to 8 hours nonstop, over a lifetime, you won't live as long as someone who's active and more fit.
Professor Mark, I have a little question here. I was a little bit worried about my fat on my belly, but now I'm worried about my heart, fat inside my heart. So it is reversible with exercise or something. May I change this? I don't know. If I start to exercise more and all of these things, this fat inside my heart will be gone and transformed in muscles again?
Yeah, I mean, the fat doesn't become muscle.
So I know.
we did a study with the HFpEF patients, and there was something called caloric restriction. So you reduce the amount of food you eat. And we found that the fat goes down, but some of the muscle went down too. The diet, and I'm not an expert in nutrition, so I have to stop there. But it's important also to watch your diet, to be active, but you also need to do some strength training. Why? Because aerobic training with diet only, we lost some fat, but we also lost some muscle. So especially for the older individuals aging, especially over the age of 50, you must do some strength training, because as you age, you lose almost half your muscle mass by 80 years of age. So it's important that you watch your diet, you do some aerobic exercise, but you also do strengthening. And you made a very good question, because we also find in heart failure patients and even healthy sedentary people, you have more fat in your muscles, more fat in your liver, more fat in your abdomen, and more fat around your heart. And that is bad, because that's very bad, because it will lead to higher mortality as well. So we also want to reduce the amount of fat in our body. And it's interesting, some people think you have to be very large and have fat, but we find some people also don't have a very, very, very high obese body mass index, and they could still have fat around their belly and their muscles. So, yes, we can change that a little bit, but you really have to modify your diet and your exercise. So it's a very good question. Yes, so diet and exercise intervention. But again, for nursing as a whole, as a nursing intervention, for primary and secondary prevention, we must encourage our patients to be active and to do exercise.
You said it on your speech that with age, we used to lose muscles.
Yeah.
This is applied on heart too, on the heart?
Oh, that's a really good question. That we call that cardiac atrophy. So if you look at individuals who go in with age, it depends because the heart may become a little bit smaller, but if you have high blood pressure, your heart gets bigger. But very interesting, as you become deconditioned and sedentary, the heart actually gets smaller. And how do we know that? because my colleagues have done some work looking at bed rest and astronauts in the space station. And if you look at the hearts with bed rest, and after going to the space station for half a year, you come back, the muscles, the quadriceps and other muscles, the calf, they get smaller, but so does the heart. But the heart is also a little bit stiffer too. So the heart with age may become smaller, but it also becomes stiffer and non-compliant and doesn't fill with blood as well. And that can ultimately potentially lead to HFpEF. So yeah, I mean, if you don't use the muscle, it will atrophy.
And there's any kind of exercise is better to the heart? I don't know, maybe.
Well, who has the biggest hearts of athletes? Unfortunately, it's not soccer players, it's rowers, cross-country skiers, and cyclists. So any exercise that is whole body, like rowing, rowers have the biggest athletic heart. And so do cyclists, and so do cross-country skiing, because they use their whole muscles. But again, any exercise is beneficial for whole body health.
It's an amazing speech, make my mind blow. And just one more question, and we finished this. There's any medicine or something to avoid that is happen or no? Just exercise.
In HFpEF, it's really interesting. All the medications, for the most part, have not improved survival. So there is no medication that has the same benefits of exercise, because exercise has benefits for the heart, the lungs, the blood vessels, the muscles, the mitochondria. But yes, I mean, our heart failure patients are on optimal medical therapy as well. So when I talk about exercise, these patients are on optimal medical therapy to begin with. They're not on no medication. They have to be, because it will lower their blood pressure or improve their blood vessels, or you know what I mean? Help their lipid levels. So these studies I talk about, the patients are on optimal medical therapy.
Well,
do you have any questions from your students at all?
I will check right now the comments on YouTube, just a minute. But there's a lot of people saying it was amazing speech. And
thank you.
And this subject is very difficult to, it's not information usual to us. So
no, and I also teach in the nursing program here, because my background is in nursing, physical education, exercise gerontology, cardiac physiology, and heart failure. And then I taught physical therapists. So I try to put not just the nursing, but the rehab and the exercise science together.
So one person asked about swimming person.
Yeah. Yeah.
Because when you swim, you training your oxygen too, right?
Yes.
There's any something related to?
And don't forget about swimming, right?
Yes,
because it's a
about
very,
swimming.
very good question. Running, soccer, you're upright. Cycling, upright. Swimming.
Exactly.
Right? So don't forget, when you stand like this, it changes the hemodynamics and the volume of your heart. So swimmers don't have the biggest hearts, but swimmers, they're very fit as well, depending how much they swim. But swimming is very good. But we just have to be careful with our heart patients, right? That they don't become too short of breath. Remember, when you're in the water standing up to your chin, you're 90% unweighted, right?
Yes.
Remember, it's called buoyancy, right? An Archimedes principle, right?
Yes.
So why being in the pool is good for some of our cardiac patients as far as orthopedics is they don't weigh so much. But also, when you sit in the pool, you have more blood coming back to your heart. So you have to just be careful that they don't become too short of breath. But for young people, swimming is very good. And our heart failure patients, too, who have orthopedic problems. but just you have to say, because before we train our patients, we say, how are you feeling today? We weigh them. Are you more short of breath? We make sure any change in your medications. And then when they exercise, we say every 5-10 minutes, how are you doing? How's your shortness of breath? We always monitor them closely. Because in the pool, when you weigh less, you have more blood coming back to your heart. And if your heart's not pumping well, you could feel more short of breath. So for our heart patients, we just have to monitor them closely. But for young nursing students and physical therapy and other students, swimming is very good because it's aerobic.
Yes.
Yes.
Move your whole body.
Yeah. So it's very good exercise.
So, Professor Mark Haykowisky, am I right? Haykowisky?
Yes.
Thank you for your speech. It was absolutely incredible. And thank you for being able to talk to us and to accept the invitation. I thank you about talking about Professor Jander. He's not here anymore, and the whole university and all the students about you're here. Thank you so much, and we wait having you here in another opportunity.
Yes, and hopefully I'll be able, when the pandemic is all done, to come visit you and give a lecture or two in person and meet the faculty and students. That'd be great.
That's our dream.
Thank you.
Professor
I
Mike.
apologize for being late. Thank you. Take care.
You too.
Bye.
Para os palestrantes que estão aqui, para as pessoas que estão aqui assistindo, o link dos trabalhos, eles vão ser disponibilizados em alguns instantes no chat, tá bom? Por favor, não saiam sem assinar. Muito obrigado para quem esteve aqui presente na palestra do professor Mark Haykowisky, que é professor da Universidade de Alberta, no Canadá, e fala basicamente sobre problemas de coração associado ao fitness, à utilização dos exercícios e como isso afeta a saúde do coração, principalmente com o envelhecimento. Muito obrigado a todos e a gente encerra mais um dia do ciclo de palestras. Nos vemos amanhã às 10 horas da manhã. Boa tarde a todos.